Parikshit.
Thank you, Dr. Marathe sir, for giving me a chance to speak on high-tech group practice. Traditionally, when we look at Dhanvantri, a doctor, a dispenser of medicine, he or she has to be knowledgeable, has to be compassionate, and has to be trustworthy. That is how is our ancient this about medical science. And of course, they dispense medicines. Nowadays, things have changed. Nowadays, the less medicines you dispense, the better your science is supposed to be. So, medical practice has changed, and today the medicine that we practice is not just science, it is an art of compassion and trustworthiness, a science of knowledge and dispensing, and as Dr. Shah was saying, there is also commerce in it that we have to understand if we have to succeed. And this technology revolution has revolutionized medicine for the better, but has brought issues like affordability and accessibility. Because technology is expensive, even though technology improves the quality of life in the long run. And it has given results that were unheard of just 10 or 20 years ago. When we look at this post-cataract surgery prescription, this is the prescription we would give most commonly during our residency days. Well, in the mid-80s, this sphere has gone with the coming of IOLs. Later, this cylinder went when phaco and small incision surgery came in. And then with multifocals coming in, even this addition has gone. And today, cataract surgery has become a refractive surgery, and ideally you don't need to give any spectacles after having done that surgery. So when we think of a modern clinic today is not just a slit lamp, a trial frame, or a trial set. A modern clinic is so much more. So if you want to do a good cataract practice, these are the things that you have to have in your armamentarium. And today it is not something that is perhaps you should have. It's almost like you should have it, especially if you're practicing in a large city or even in tier 2 or a tier 3 town. The same goes true for doing good glaucoma practice, where you have to have so much of gadgetry that were there, where earlier only perhaps a direct ophthalmoscope and a perimeter or a Jerem screen would do the trick. Similarly for retina, and the changes that have happened in retina practice in the last 10 years have been enormous. They have been huge, and we can today give good results to patients whom we would classify as visually impaired just 10 or 15 years ago. Similarly is happening in cornea. And because of this, one, patient satisfaction has increased tremendously. Patients are living longer. Their visual demands have multiplied. They need mobile phones, televisions, computers, they are driving. I do a lot of rural practice in Baramati also. Earlier when we would do a cataract surgery and a patient sees unaided 618, patient would be very happy. Now even if they are farmers or rural patients, they all have mobile phones. So even if they are illiterate, they want N6 vision. A lot of them drive even at a very old age. So they want very good distant vision, and they want it without spectacles. And this communication revolution has also tremendously increased patients' expectations. And I think this is possible only if we have a good, fully equipped high-tech center, which can give the physician everything that is needed to meet the patient's demands. Corporate hospitals and NGO hospitals are also doing this, and they have raced ahead because they have all of this under one roof. Perhaps the direct cost may increase to the patient, but patients still like it because the indirect cost is less. And because of this high cost, which is cost intensive, gestation period is high, ethical practice, which is not just morally good, but is also good in the long run, is professionally good, has now become endangered. And this is where group practice comes in, because new technology will keep on coming all the time. And in the group practice, which is already a norm in the Western world, the risk is shared, the investment is divided, and the headache is taken care of if the group itself is not a source of heartburn or a headache. And like a bundle of sticks, it is always stronger than a single one. So I would like to just quote an African proverb. We have so many of them here. In Africa, they say, if you want to travel fast, travel alone. But if you want to travel far, travel together. So this is, I think, in group practice is needed, because if you're looking at an ophthalmology career of 30 to 35 years, then it's not a question of if, it's just a question of when we will all be shifting to group practice. Thank you.
Dr. Parikshit, I think the importance of group practice he has explained altogether. Any questions?
So our practice is quite new, just about 2.5 years old. I think the disadvantage is only if you think it is a disadvantage is you cannot have your own big ego like you have in your own private practice. And secondly, in group practice, all the dealings have to be very, very transparent. Only then the group practice will.
Thank you.